So, as I understand it, we'll have a question and answer after the first session. In the second session, we do have a microphone that needs to be passed around, and it's really to be able to hear the questions. So they've got me hooked up for sound and for everything else, evidently. So good morning. First off, I have to make sure that we understand that the opinions of Dr. Dekker are not necessarily the opinions of the Department of Defense, U.S. Army, the U.S. Public Health Service, or the Indian Health Service. I grew up in Michigan, went to Michigan State University for my osteopathic degree, did my internship and residency and fellowships in Chicago, practiced in Chicago as a public health service staff member from 82 to 94, then moved to Kansas City for 4 years. I was professor and chair at the University in Kansas, and then I moved to the Indian Health Service in 1998, stayed there until 2010 as the director of the Phoenix Indian Medical Center programs, which is the largest Indian Health Service facility in the country, and then came to Fort Belvoir in early 2011. So the content of these presentations are really geared towards my opinions. I try to make sure that we have evidence that supports my opinions, and we'll have several references that you can look at, but that doesn't mean that they're fact. And I think the way to look at medicine as we talk about it is the same thing goes for social work and psychology, the practice. And so these are my opinions. Now, I tend to be opinionated, so sometimes I become a little passionate about it. But at the same time, I think that all of us in this room are very interested and dedicated and spend a good part of our lives working with and working for people who carry the burden of addiction. And so it's really themed on that, from that standpoint. The first presentation is going to be on how do we treat chronic pain and the realization that we have an epidemic. And that epidemic is critical in this country right now. We have increased the amount of opioid pain medication given to patients by 5-fold over the past 12 years. We have now caused the leading cause of accidental death in this country to become overdose of prescribed medications. It now exceeds car accidents, exceeds drownings, and when you look at, now there's all kinds of causes of death, but accidental death is a significant part of the trauma and loss of life years. Because when you die from cardiovascular disease, you're a little older. When you die from pulmonary disease, you're a little older. But when you die from accidents, you're a lot younger. And accidental death, unfortunately, has taken a significant toll. Everyone in this room has probably known someone who's died from some medication overdose. And these are not suicides. These are accidental. The young man who just died in British Columbia, who's the actor from Glee, he wasn't trying to kill himself. He was on heroin and alcohol. Now that's not a prescribed medication. But the thing is that when you look at people who die from OxyContin, Opana, fentanyl patches, Vicodins, Percocets, that's a very common issue. Now, when I say I'm not representing the federal government in any way, I want to make sure it's understood. I'm speaking as a private citizen. My academic position's at GW. The reality is that when I give you this information, it's not like Dr. Dekker from the Army said this, it's Dr. Dekker, private citizen, said this. So I want to stress that. These presentations have been vetted by our Public Affairs Office. It's not an easy process to get that done, and so we'll stay on track with that. So we start talking about pain. Now, somebody who took the course last year will see some similarity in this, but we're going to expand it a bit because we've now done a little bit of analysis of data. In the military, they have an organization called the Warrior Transition Unit, or it's called the Wounded, Ill, and Injured. And these are people who have complex injuries, so it's not just an amputation. It's not just a traumatic brain injury. It's a combination of several things. And so the classic one that I see are people with PTSD, traumatic brain injury, substance abuse, many times other types of painful type injuries, herniated discs, it's called complex regional pain syndrome when you have a piece of shrapnel go through you and it just hurts all the time. The pain doesn't go away. Now, the assumption is, and there's pain clinics everywhere, and unfortunately some of them say this, do not live with pain. We can take your pain away. Have a pain-free existence. Even Don Berwick, who was our former director of CMS, prior to that, and now currently he is the director of the Institute for Healthcare Improvement. And so they are going across the country saying, we can improve your practices here by doing the following. He wanted to have a pain-free knee replacement. And I remember when he said that, I said, well, I'll tell you what, I don't think it's possible. He ran the Boston Marathon and pushed himself down to just bone on bone. Well, there are some things that just can't be done. We cannot take all the pain away from some problems. Now, we can decrease suffering. That's very different than taking all your pain away. We know the pain of addiction. We never tell people that we're going to cure your addiction, right? We don't tell people that because this is something that's different. Addiction is a genetic disease that increases your probability dramatically if you have the genes to predispose you to out-of-control use, continued use despite negative consequences, cravings all the time, trying to cut back, you can never continue doing it. And so we understand the disease. The thing is that in order to treat the disease of addiction, a person has to be able to change. My command asked me when we opened, our program's a brand new program at Fort Belvoir. They have never had a locked inpatient treatment program for substance abuse in the world. There's no program in the military that's like our program. The thing that happens though, we only take active duty service members and there's a waiting list all the time to get in, so we spill out on a regular basis. But what's interesting about this is that it's a bit of an enigma to a lot of people. So one of the comments was, what do you actually do? What is it that you do on this program? And I remember telling my former command, I said, ma'am, what time do you come in? She said, I usually get in about 6:45. I said, you know the beautiful lawn we have in front of our hospital? I would like to see 20 service members out front doing Tai Chi as the sun's rising, so they can feel what it's like to have the first light touch their face and to feel their minds clean and open. She said, okay, I want to ask that question over again. What do you actually do? I said, all we are agents of change. That's what each of you are. You're just an agent of change. I don't know who the most important person in our program is, but it's not me. Because our receptionist may be the most important person, because the most important person is determined by the patient, not by the providers. It's who connects, who makes sense, who touches you, who helps you change. So as we're going through this, keep that theme in mind, that when a person comes in and they believe their problem is they just don't have enough Percocet, and that's their number one problem. And those patients who come up to you and say, Dr. Dekker, you're the only doctor that knows what I'm going through. I've been to so many other doctors and you know how to take care of my problem. And I want to thank you from the bottom of my heart for being that one person in this world who can take care of me. Be afraid, because that person will gut you like a fish as soon as you don't give them what they want. Now, at the same time, does that mean we run away from those patients? Does that mean we say they can never be helped? No. But you got to make sure you keep your professional distance and make sure that you know what your role is to help that patient change. That patient doesn't change because they're happy. That patient doesn't change because things are going well. And that patient doesn't change when you write that script for another 90 Percocet. So the goal that we're going to have here is we don't want to take away the ability to treat their suffering. We want to improve their function, but we also want to keep in mind that we are prescribing way too much opioid in this country. And that goes for our military staff and our civilian staff. So when we start looking at this, we want to recognize one thing. Non-malignant pain, that's what we're talking about. So I'm not talking about people who have cancer, and I'm not talking about people who have chronic, unrelenting, painful disease. Chronic pancreatitis is a terrible disease. Some forms of rheumatoid arthritis, systemic lupus erythematosus, all those diseases that are chronic and degrading can cause severe pain. So I'm not talking about that population. 70% of all the opioid in this country are written for low back pain. Now, what's interesting about this is that, as it turns out, opioids are not a good treatment for low back pain. But when you start taking them, you can't stop. And when you can't stop, you will find someone who's willing to give you what you need. We just had a doctor arrested in Arlington who was giving medications to our service members, and he had a thing called a party pack. Number one, you had to pay $100 cash to see him. He saw over 100 patients every morning. Number two, you would receive 3 prescriptions when he would walk in. He would never use a stethoscope. He would walk in, he would give you the blessing, and then you would get your 3 prescriptions and you would leave. The 3 prescriptions were OxyContin 40, number 60, 1 BID. Second one was Xanax 2 milligrams, number 90, 1 TID. And the third one was Adderall 20, number 60, 1 BID. And you got to go back on a regular basis. Now, the Virginia monitoring program picked this up. As it turns out, he made a boo-boo. The boo-boo is, if you take 60 tablets, 1 BID, it should last a month. But if people go back every week, there's a problem. And if you use the Virginia monitoring program, you can actually pick up the doctor, the pharmacy, and what was prescribed and how often they're supposed to take it. And if you're taking it too often, that's a problem. And if you're getting it too often and not taking all the medicine, that's a problem, because then where's it going? Well, we don't pay an E4 that much money. I hope you understand that. And this is Tony Dekker's opinion. But when I have service members whose families are on food stamps, it's an embarrassment that we're not taking care of them. But a person who has medication that can be exchanged for money is a bad combination. And so when you're giving somebody an Oxy 40 on the street is $40 to $50 each. And so how can a person who's on an E4 salary go in and pay for a $100 doctor visit cash and then buy the medication cash, because then it's invisible to TRICARE. We can't see it. And so we have to do our job and go and review the information. Your own patients that are in the state of Virginia, you can follow. Now, if they're in the state of Maryland, you can't, because Maryland does not have that system active and running yet. And so it increases the work, but if you want to provide safe care, you have to be able to do that. Now, I lived in Arizona for 13 years, and there's a thing called the State Medical Board. Now, the State Medical Board is the organization that determines the practice of medicine in each state. And there's an organization that unifies all the state medical boards called the Federation of State Medical Boards. And so the FSMB.org is how you find out if your doctor's gotten into trouble or not. You can actually, there's a thing called docboard.org, and you can just check, put in Tony Dekker, find out where he's in practice. I'm licensed at 4 states, and you can see if Dr. Dekker's ever had any run-ins with the board. Now, most doctors don't want to have any visits with the board. And that's because the board does 2 things. It takes your money and gets you in trouble. Now, you don't want to get into trouble. You're happy to pay the money. Now, the thing that's interesting in the state of Arizona, the number one reason that doctors would get referred to the state medical board was the overprescribing of opioids because somebody died. The number 2 reason that people get referred to the medical board was because you didn't treat pain adequately. Oh, we got a problem now, don't we? Matter of fact, in all 50 states and all U.S. possessions, the overtreatment of pain with opioids and the undertreatment of pain are in the top 5 of every state. So now you're starting to see the complications. We asked our doctors at the Indian Health Service, if you could avoid writing for any Schedule IIs. Now, Schedule IIs would be Percocet, OxyContin, Opana, fentanyl patches, morphine, MS Content. If you could avoid writing for the Schedule IIs, would you choose that option or would you continue prescribing? 75% of our doctors said, can someone else take these patients because I don't want them? Now, the number one reason that service members are seen by physicians is still pain. That's not, by the way, the number one reason in the general population. General population tends to be healthcare evaluations or annual physicals or annual exams, things like that. But the number one reason that service members see a healthcare provider is for the evaluation and treatment of pain. So pain is a huge issue. Now, When you were wearing your body armor, you had 45 to 50 pounds of body armor, a 4-pound helmet if you had the night vision on top of it. You had a weapon that could weigh up to 16 pounds and a rucksack that could weigh another 40 to 50 pounds. And you're going to go on an 8-mile run. You're going to take a target out and you're going to come back. How long can your knees last when you do that? On rough terrain. A very good friend of mine just passed away, Dr. Patricia Elliott, who was practicing just north of Charlottesville. She was 80 years old. She moved to Virginia from Michigan back in the early 70s. And at her memorial, just before she died, she asked me to come down and read her some Robbie Burns. She's an old Scot. And so I'm reading Robbie Burns out of the book from her library, and I get to this thing, and he says, sometimes it's good to take a wimble. I said, a wimble? What's a wimble? She said, well, look it up. There's a glossary in the back. So I go to the back, and it says, a wimble. A wimble is a walk. Sometimes it's good to take a wimble. But right under wimble, there is a word named wumble. And it says, I said, a wumble is a walk over uneven surfaces, a little bit more challenging. It was kind of cute because she smiled and she said, I like the wumbles. Well, we don't send people out on missions that are on wimbles. You know, Afghanistan is a very rocky place. And so what happens is you have people who have to be very vigilant, because if there's an alteration in the terrain in any way, there could be something buried underneath there. I mean, IEDs are still a major cause of injury to our service members. And then if you're carrying 100 pounds of stuff, you got to be very careful how you plant yourself and traverse over that rough terrain. So back injuries, all the time. Knee injuries, all the time. Hip injuries, all the time. You take a tumble and fall. You don't fall on a flat surface. You fall down an incline or a decline. And so what happens is that it's a dangerous situation just from a musculoskeletal standpoint. So we have a lot of people who have chronic pain type issues, and at the same time we have all these challenges. The DEA controls prescribing all these controlled substances, and they have the right to come in anytime and just say, I need to take a look at your charts, I need to look at what's going on, and it's important that they do that. They're there to protect the community. They're there to protect the public. If we have a doctor who's, just before I left Phoenix, I got called up by the DEA because I have a close relationship with them, and they said, Dr. Dekker, we need to ask you a question about a dermatologist. I said, what's the problem? They said, well, is it appropriate for a dermatologist to be prescribing Dilaudid? I said, well, it depends. Is it a derm oncologist who's taking care of melanoma and other things like that? They said, no, 80% of this doctor's patients have acne treated with Dilaudid. They arrested him that afternoon. Now, so what happens is that a doctor has to function within their normal scope of practice and what's considered to be standard of care. If you have standard of care, then you have to say, okay, what is the way that we actually approach this? The same thing goes for social workers and psychologists. There's a standard that we have to adhere to. So we can't just use hunches. We can't just use, well, this one person is really different, and so we're going to cut them some slack. This person doesn't want to have urine drug testing because their religion prohibits them from doing it. I said, what religion is that? You're laughing about that, but remember, one of the pathological conditions for an addiction is dishonesty. Dishonesty with themselves and dishonesty with those around them. So people say, well, and I'll ask the question, why do you have a hard time working with alcoholics or addicts? And I did grand rounds at our hospital yesterday, and one of the comments was, well, they lie to you. And I said, well, yeah, but so do your diabetics and your hypertensives. I mean, this is a chronic illness. Of people who have hypertension, only half of them know they have it. Of the half that know they have it, half of them see their physician or see their provider, get medication, and take it. So only a quarter of people with hypertension have controlled hypertension. Of the people who are diabetic, only half the people in this country who have diabetes even know they have diabetes. I can go down the list, by the way. So asthmatics, HIV, liver disease, these are chronic illnesses. Of people who have addiction, a significant percent, we think about 70% of people don't even feel they have an addiction. They think this is just normal life. I drink a six-pack every night. I work hard all week long. What is wrong with that? Well, as it turns out, drinking a six-pack every night is going to have negative effects down the road. Let's talk about that. Now, if I can't say, well, you're an alcoholic, what happens then? Immediately, the wall goes up, and because they hear that from everyone else in their life, right? So we're just doing the same thing. So part of all this, remember, you're agents of change. If you want to motivate that change, you have to be able to get in. Now, I don't want you to think that I'm predatory with my patients, but I remember when I was 7 years old, and my grandfather took me fishing. Now, my dad's attitude of fishing was, there's a kit, go fish. My grandfather actually enjoyed sitting down and saying, okay, here's the thing. You got to find a nice big worm. You don't want to get a worm that's not moving. It's got to move around a lot. It's got to wiggle in your fingers. You don't want to touch the worm a whole lot because the worm is going to make a lot of slimy stuff, and that's actually fish food. So don't make it come. So you pick the worm up, you slide the hook all the way through that worm so it just barely sticks out so the fish can't see the tip of the hook. Then you want to have at least 3 feet between the worm and the bobber, and you gently lay the bobber on the water. And that worm is going to wiggle around. You should see it wiggle around in the water as it's starting to sink underneath the bobber. Now, that worm is saying to the fishies, it's dinner time. Come on and get me. And the fish are going to come and they're going to sniff. And when they sniff, it's going to make the bobber move a little bit. But the bobber won't go under the water when they're sniffing. So don't pull back when the bobber moves. You got to wait until the bobber goes under the water. When the bobber goes under the water, then you want to set the hook. The same thing goes with motivational interviewing. You know, patients will check us out. And sometimes they check us out through other people. They talk to the receptionist, they talk to other staff. Well, what's going on with that Dr. Dekker? And so you have, and if it happens to be that your staff have read you as an uncaring son of a bitch, then you're not going to be very popular with the staff, and you're not going to be very popular with the patients. And so the goal here is that you're a team, right? We're a multidisciplinary team that works together. That doesn't mean we're all kumbaya, but that means that we're working together in a way that says we have to work together to be agents of change. Now, some people like to change people by grabbing their arm and pulling them, kicking and screaming all the way to where we think they need to go. Turns out that's called treatment as usual, TAU. It doesn't work. And so we have to actually get in their head. Had a service member tell me the other day, I'm working with him, and he looks at me and he takes a deep breath. He says, listen, I don't have enough real estate to give you room in my head right now. And I thought, what a great response. Because he picked up on it. I said, so we got to get under their skin, we got to get into the system, and we got to make sure that they realize, number one, we care. Number two, it's not just our opinion, it's because we have some experience that allows us to make the statements that we're saying. And number three, they have to do the heavy lifting. If you're doing more work for your patient than the patient's doing for themselves, the wheel's going to fall off the cart, and nothing good happens after that. So we got to, again, motivate for change. So as we're going through this presentation, you can see we got reasons to be concerned, but we also have a real reason to actually make this happen, because there were 24,000 people last year in this country that died from prescription drug overdoses. So it's a sad situation. Now, where do all these drugs come from out in the field? What's interesting is that if you look at this, people started thinking that maybe it's the internet. We got to blame something, right? Maybe it's those drug pushers that are out there. I mean, there's so many of them out there. And so we blame things that we have no control over. The reality is 75% of the opioids that are abused in this country are from friends or family. 55% are for free. Man, my back is killing me. You know, I think I got some Opana left over. Or, you know, when Grandpa died, I got a big bottle of whatever. Now, these reservoirs of opioids in the community are very dangerous because there's a thing called farming. Now, farming is not when you put things in the ground, they grow. Farming is P-H-A-R-M-I-N-G. That is when, hey, Grandma, can I use the bathroom? Yeah, flush this time. So they go in the bathroom, they flush the toilet, they open up the medicine cabinet, and they see Xanax and OxyContin. Now, they don't take all of them because kids realize that Grandma's going to figure it out. They just take 2 Oxy-80s and 2 Xanax 2-milligram tablets. They put them in their pocket, and they say, thanks, Grandma. Did you flush? Yes, because we're focused on domestic issues. He's focusing on what's going to happen on Friday night at the party. So he's going to trade those 2 Xanax for a marijuana blunt. he's going to trade those 2 oxy-80s for $50 and a fifth of Jim Beam. It's sad because it's gotten to that point, that these actually the drugs have become commodity. And there are more people dying from prescription drug abuse than from heroin, cocaine, methamphetamines, bath salts. I mean, this has now become the #1 drug problem in this country in regard to severe consequences. So we need to look at it from that standpoint. Now here's the other thing that's kind of difficult. Of all those drugs that come for free from friends or family, 80% are coming from one doctor. So we do know that there are doctors in the community, and maybe it's because of sins of omission. In other words, this is the way they always practice and they just didn't know that you shouldn't do this. Or sins of commission, they're making a lot of money with that practice of promoting drug use in the community. And so we call them candy shops and party packs. And there is a significant effort to identify those individuals, but it's very difficult because the doctors who are prescribing these things that are really egregious in behavior, they tend to move around. I have a son that just left Broward County to go into practice in Baltimore, and he said that Broward County, it was crazy. He said it got to the point that, he said at Broward County Hospital, he said if you were going to admit a patient who was not on opioids, it was a surprise. Because everybody was, 18 to 20 admissions a day, everybody's on opioids. And like I said, 86% of the men and women who were in the Wounded Warrior Battalion in 2010 at Walter Reed were prescribed opioids. They weren't in because they had severe pain. They were in because they have complex problems. 86% were on prescribed opioids. Military response was, it's got to change. 2012, it dropped to 17%. Now, when you go from 86% to 17%, what happens in the meantime? People who have pain may not be getting their pain treated adequately. So complaints went way up again. So now I'm seeing the pendulum start swinging. And when you have those wide swings in any practice, when the way you practice changes dramatically over each year, there's something wrong. We've got to take a step back. We've got to figure out, okay, what's going on here? How can we adequately evaluate and treat suffering, and how can we adequately make sure that we're not causing more harm? Now, the National All Schedules Prescribing Electronic Reporting Act, NASPER, was signed into law by President Bush II. And it said that we had to have a way to monitor prescribed medication. And so one of the things is that across the country, the purple states are operational right now. So this is 2013 data. And Maryland, now they made a little boo-boo because that little thing hanging down off the east coast of Maryland is actually Virginia. But Maryland has not gone live yet. They're going to go live this year. But you can see they still have other states that have not gone live. The problem is that West Virginia doesn't talk to Virginia, and North Carolina doesn't talk to Virginia, and so could a person go down to Fort Bragg and then get medications on the outside, then come up and see us, and then you see what's happening? And our system, the military and the VA do not contribute data. So you see a person down here, they're visiting in Williamsburg, and they say, listen, I'm an active duty service member, I'm on a furlough right now, but I can't get up to Portsmouth and I can't get over to Fort Belvoir right now. I got a piece of shrapnel that went through my leg right here, and I'd like to get some medication for it. It's really been bothering me. I can't sleep at night. I can't take codeine. I'm allergic to codeine. And the doctor told me I shouldn't take any more acetaminophen, so I shouldn't take any Percocet. But there's that medicine. It's called Dilaudid. Yeah, that brand name, please. That medicine works really well. Now, I'm going through the sequence to give you the sequence of how they work us. So those people who call at 4:59 in the afternoon, those people who call at 3 o'clock on Friday afternoon, Dr. Dekker's not in town today. I was just getting a call as I'm talking to you in regard to, I need my medication right now. I said, well, Dr. Bergman's back there, but quite frankly, I'm not going to be able to take care of it. I'm down here. Well, can't you go to a Wi-Fi area and use your government computer and put it in? Now, but the thing is that, remember what I said? Okay, you have a thing called a sternum right here, and then a pubis down here that gut you like a fish. So what I'm saying is that you don't want that to happen, and we don't want to promote their maladaptive behavior. I was seeing a patient yesterday. I got a call from another patient who's in Dover who says, I just had surgery in Wilmington and I can't get a hold of my orthopedic surgeon and I'm out of my medication. I need Oxy 40 3 times a day. And I said, well, why can't you just go to Dover? I mean, you're right there. The doctors over here don't like me. I said, well, you do understand I can't call in Oxy 40. It's a Schedule 2. Can you call in Vicodin? I said, now, so we're laughing about it because we're nervous, because this is what happens in our lives when we work with patients. And so if we want to be an agent of change, I'm really sorry that you're going through this. You need to talk to your orthopod. If you need something from me, you have to come down and see me. Well, that's like 4 hours away, Dr. Dekker. Let me say it one more time. If you want to get something from me, you have to come down and I have to see you. So it becomes a challenge. But this is one of the mechanisms that we have to make the system safer. Now, I had a patient who told me that she has no idea how someone got her identification and went to 4 other doctors in the Northern Virginia area to get those medications. I said, well, that's pretty serious. We better get identity theft involved. We better go down to the police station, get a police report in there, and by the way, I need to have some urine drug screening. Why do you need that? You haven't given me anything. I said, no, you haven't gotten anything from me, but it says that you went to 4 other doctors in the past 3 weeks to get a variety of different medications. And you're telling me that you've not taken those medications, that someone has stolen your identity. So one of the ways to prove that is by going to the laboratory and dropping some urine to show that your urine is clean. She got up, she walked out, end of visit. Now, is she happy with me? No. But did I do the right thing? You see what's happening? Now, the sad part is she can just go to another doctor. So as she's getting up to leave, I said, ma'am, we actually have a treatment for this disorder. She said, will you give me my prescriptions? I said, I will actually see you and we'll get you into treatment. I said, you have a disease that has one outcome if we just wait and see what happens. Because I personally believe that the outcome is death. I personally believe that if a person's allowed to just wait and see what their addiction does, they will succumb to this disease. Now, I'm not always right. I had a Marine, 4 tours. He's at Annapolis. He's a great guy. He's a hero. But he drinks a 5th a day. And so when his wife brought him in, he was in our unit for 3 days. And I want to give factual information to our service members. So I said, if there's 100 people in this room and every one of them wants to stop drinking, and they're all alcoholic, we know that 8 of them will be successful if they do it on their own. We also know that 92 of them will relapse and go back to drinking, and probably drinking even more than they were drinking when they came in. That's with nothing. Just come in a room, they all say, I want to stop drinking, and we let them do what they want. They sort of spread out, and they figure out how to do it on their own. Now, we know that people who get treatment, their prognosis jumps up dramatically. And so it goes anywhere between 30 to 70% are sober after a year, depending on what kind of treatment they get. It doesn't mean every treatment is the same, but we do know that treatment works. And this guy stands up, he says, I'm one of those 8%. I'm going to prove you that I can stay sober. I said, you're going to just leave? He said, I'm leaving. So, and our program's a voluntary program, right? There's consequences for leaving. So he signs all the form, his command comes in, his command says, you have 16 years in. You're going to walk away from 16 years? And he said, I'm out. I'm not going to let someone tell me what to do. He said, I have done too much for this country to listen to someone else tell me what to do. At that time, I thought I had failed. This is in March. I get an email from him every week, and he says, this is Captain Blank. I want you to know I am still sober, and I am going to prove you wrong. And I said, Captain Blank, I am happy that you're still sober, and I have no problems with you proving me wrong. Now the thing is, if I said, the only problem is, you're not happy about your sobriety. And people who are not happy about their sobriety typically don't stay sober. Now what's funny is that he emails back, he said, I didn't say it was easy. Now, this is kind of interesting because, and I apologize, what this says is, this is a big pie chart here, and it says, of the people who have an addiction in this country, and we're talking about 20 million people. This is 2008 data. This is from the National Survey of Drug Use and Health. Of the people who have an addiction, 95% don't think they actually need treatment. They can do it on their own. They're just like my captain. Of the people who think they need help, which is only about 5%, only 1% of the whole population actually go and get the help they need. 3% know they have to have help, but they don't get into it. So for every person that you have here at this campus, for every person that comes into your office and says, I think I have a problem, there's 99 other people who need help that don't either think they need the help or won't make the effort to get it. That tells me one thing. For the person sitting in front of me, I've got to do a really good job. I've got to really be an agent of change. I've got to let that person know that I want, I'm motivated, and we can provide them with the care that will get them from a using point to a sober point. Sobriety, by the way, is not abstinence. Sobriety is a full life without drugs or alcohol. And that's the key, is that I got a young man come in. He just got discharged 2 weeks ago. And he was very sad. And he comes into my office yesterday, and I got my therapist in, and he said, I've been just locked up in the barracks for 2 weeks. I don't have any friends. I don't have anyone to talk to. I can't go to a meeting off the base because I'm confined to the barracks. I'm dreaming about drinking again. I really want to drink. He said, this is what I would do when I felt this way. And so I put Eugene with him, and Eugene said, listen, let me make arrangements with your sergeant so we can take you off the grounds and get you to a meeting every day. Let's get you going. You have to meet some people. You have to see other people who are sober and happy. Because if all you see is sober and sad, it ain't going to work. And so we got to think about that. And so a lot of times in the military, the assumption is we're going to control you. We're going to help you make the right decision. And so what we do is we tighten the noose. Well, that doesn't really help, because the whole purpose of being an agent of change is that we're not the ones changing. We're the ones that stimulate the change. And that means that we have to give them some rope. We have to let them have a little bit more ability to make a mistake. In the military, we don't allow a lot of mistakes, though. So the relapse to me is not something that involves picking a bottle up and drinking it. Relapse is predictable. You can see the change in that patient before they do it. And so we need to have our finger on the pulse on a fairly regular basis to make sure the patient is moving in the right direction. If we don't do that, we fail. And if we fail, they fail. And I'll tell you, it's a tragedy when a person relapses. It's a greater tragedy when you have active duty service members that lose their GI benefits, lose their veterans benefits, so now they can't get care. And this happens, unfortunately, on a fairly regular basis, because how many times do you let a person who's injecting heroin do it? How many times do you let a positive cocaine urine drug screen go through the system? How many times do you let a blood alcohol 300 and someone punching holes in the walls or beats up their wife? It can't be forever, right? So we have to have something better that's in there to make sure these men and women get the help they need. Now, when we look at worldwide injection drug users, we find an interesting piece of data here. And I want you to pay attention over here to the right side of the curve, which is if it's increasing or decreasing. In the United States, or I would say in North America, there's 1.4 million injection drug users, and we're relatively stable. But the areas where it's going up is Eastern Europe, and there's an epidemic of injection drug use going on in Eastern Europe right now. There's a new drug on the streets. It just got identified in Baltimore called Crocodile. It's desmomorphine. Crocodile is K-R-O-K-A-D-I-L. It has 4 times the affinity of heroin. Now that means that it stimulates that mu receptor 4 times greater than heroin does. Now, heroin, by the way, is just morphine. So desmomorphine stimulates it 4 times as much. So your high is much, much greater. Now the problem with Crocodile is it causes severe phlebitis. Now the way that God made us is that we have a nerve, an artery, and a vein all in the same area called a neurovascular bundle. And when you cause a phlebitis in the vein, you destroy the artery and the nerve. So if you keep on injecting, every time you inject, the picture that we got from Baltimore was a patient who had just started using Crocodile 2 weeks earlier, and the left arm was all streaks where the veins were all being damaged. But from Eastern Europe, there are numerous patients who have lost limbs because it kills off the arteries and kills off the nerves. So they don't feel it, but their vessels, their blood vessels have been damaged, their nerves been damaged, and now they're not delivering oxygen to the tissue, and the tissue starts to wither away, and bones start sticking out of their arms and sticking out of their legs. And they don't feel it. Now, addiction is insanity, right? But just Google Crocodile, and I mean, it's amazing what's happening right now in regard to the damage that's occurring. But Eastern Europe, Southeast Asia, Eastern Asia and the Pacific, North Africa, Sub-Saharan Africa, and Latin America, all increasing use of injection drug use. Now, the sad data is, for people who inject themselves on a daily basis, 20% die each year. So you put all these numbers up right here, you start to realize we're having hundreds of thousands of people who are dying from complications of injection drug use. It's not just HIV. You know, if you inject enough cocaine in your veins, your heart stops working. So what happens is that there's all kinds of other causes for death, infectious causes and direct causes of the drug. Now, when we try to evaluate a patient for opioids, there's all kinds of tools, and these are standardized tools. And yet, many of us don't do it. When a person comes in a chronic pain setting, we don't evaluate the patient to what's considered the standard of care. And that's an important thing for all of us to do. So what happens is that there's a whole variety of standardized assessment tools that can be used to treat patients with pain. Is it appropriate to treat a patient who has pain? Yes. Does that pain treatment always require an opioid? No. Now, are opioids appropriate to treat pain? Yes. But we need to, so you can see where we're going. It's a path that we need to go down. Appropriate evaluation, and it, like it was said earlier, this slide said it's all available to you. So I mean, this is something that you're welcome to have. But the reality is that we're trying to make sure that the patients who have pain are appropriately evaluated and we decrease their suffering. Now, is it possible to decrease suffering without decreasing pain? Absolutely. See, the problem is that people consider pain and suffering as equal. Each of you respond to pain differently. Pain occurs here. It does not occur in your knee or your hip. Inflammation occurs at your knee. Tissue degradation occurs at your knee. Bone-on-bone physical irritation occurs in your knee. But pain is perceived and processed up here. So pain is a brain disease. That should sound familiar. Because what did Alan Leshner say just 15 years ago? Addiction is a brain disease. And so when you start putting this together, the two start going hand in hand. Now, 2003, so 10 years ago, Keiko from Sweden did a very interesting study. Sweden did not allow agonist therapy. Agonist therapy would be methadone or buprenorphine, which is now called Suboxone, but there's a variety of generic substances too. And so the injection drug users, the heroin addicts in Stockholm, their only option was clonidine, maybe some other medications to deal with withdrawal. Now, how do you describe opioid withdrawal? What does it look like? A bad case of the flu. Well, this would be a really bad case because Dr. Dekker's definition of opioid withdrawal is if you have a hole, something is flying out of it. So your tears, your runny nose, you're vomiting, you're pooing on yourself, you're peeing, you're sweating like crazy. There's only 3 holes that don't have anything coming out. It's your vagina and your ears. Everything else, there's something flying out. And when I say flying out, I mean the patients who are going through bad opioid withdrawal, they are literally on the can with a wastebasket in front of them. Now, David Smith from the Haight-Ashbury coined the term cold turkey. And that's because you get goosebumps all over the place. And he also had talk-down therapy, which was quiet room, someone who cares about you, and a bucket so you can vomit and poo in. That was going to be the way that they did heroin withdrawal back in 1967 at the Haight-Ashbury. Now we've gotten better than that. And David now, just like most addiction docs, will use buprenorphine for the withdrawal process. Now what's interesting is that what Keiko did was he had 40 heroin addicts and everybody got 6 days of detox. So they got 6 days of medication to withdraw them from the opioid. Then they were randomized, and this was a double dummy test, which meant everybody got a substance every day, but the doctors and the patients didn't know what it was. So after 6 days, they go through withdrawal, and then they're randomized into some people got buprenorphine and some people got the placebo. The green boxes are the placebo people, and you can figure out how quickly they figured out it ain't working, okay? So these are the people who drop out, and they dropped out quickly. Now, one person lasted 61 days. Now, this program, this intervention was interesting because Sweden has a very lush residential nutrition, job placement, counseling service program, but they didn't have agonist therapy. The people who were in the experimental arm, the red circles, one person drops out immediately. That person went back to doing what? Shooting heroin. Over the course of a year, 4 more people drop out. So 15 people in this program are still in treatment a year later. I mean, think about treating alcoholics. How many of your patients are still in treatment a year later? Not many. Okay, so this is able to retain 75% in treatment of IV drug abusing patients. Nobody in the placebo arm was able to last longer than 61 days. Is it possible to stop heroin without anything other than talk therapy? It is. Is it easy? It's not easy. The key in treatment is not the medication. The key is adherence to treatment. One of the things that I have in my consent forms, and this was actually put in by Shirley Matt, my addiction therapist back in the Indian Health Service. She said, she walks in my room and she throws my consent form on my desk. She says, "You think this medicine cures addiction?" I said, "I never said that." She said, "Well, then put it on a piece of paper." I said, "Shirley, stay here. Tell me what to put." She said, "No pill cures an addiction. This medicine helps you stay in treatment, and treatment is where you begin to heal." And so you have to understand, it's not Vivitrol, it's not Suboxone, it's not a Camprosate, it's treatment. All we're using the medication for is keep them in treatment. If people are in treatment, they typically do well. Even when they relapse. I got a telephone call yesterday. I had a sergeant sitting in my office waiting area. I walk in, I said, "Are you here to see me?" He says, "Well, not really." Now, I'm busy. Okay? I didn't get out of work last night till 8 o'clock. So my thing is, if you're not here to see me, great to see you, shake your hand, I go to the next patient. He had relapse that day. He did not want to tell me. I get a telephone call this morning from his therapist, and she said, "I got to let you know that Bill relapsed yesterday." I said, "What time?" She said, "In the early afternoon." I said, "He was in my office at 3 o'clock, and he didn't want to talk to me." And she said, "Well, he did want to talk to you, but you look really busy." I said, "Sue, I'm busy all the time. You can't use that." She said, he came in because he felt really bad. He went to the bowling alley because he wanted to just get away. There's one thing problematic at the bowling alley. Yeah, right. And so he's at the bowling alley, and then his buddies see him, and they all have cold beer, and it was not a hot day yesterday. It was a nice, beautiful day like today. So he didn't have that for an excuse, and he said, "I don't know what it was." He said, I hear him talking in the background. "Is he mad at me?" I said, "Bill, let me talk to him." I said, "I'm not mad at you." I said, "You came in." I said, "But I'm disappointed that you didn't say, 'Doc, I got to talk to you right now,' because you're just as important as every other patient there." But the fact that he came back is a good sign. The fact that he wants to re-engage in treatment is a good sign. This is a disease that it's expected that people will have relapse-type events. Now, if they relapse and don't come back, it's a bad sign. If they relapse and come back because something changed in them, they actually feel like, I don't want this. That's a good sign. So I use relapse as a therapeutic tool. So the goal here is, how do we make this work? In this situation, it's interesting too. Remember I told you 20% of people who are injection drug users die every year? That's the data for the US, that's the data for Sweden. And when you looked at all these people on this list that are injecting themselves, if I get this to work, you can see we're going to have a significant number of people worldwide that are going to have this problem. Eastern Europe, by the way, the Russian crime scene or crime syndicates have a stranglehold on Eastern Europe and on Russia right now. The majority of Afghani heroin, which is 90% of the heroin in the world, goes to Europe and Russia. What we're getting here in the US is mostly Mexican right now. So it's interesting when we start looking at that you know, it's a multi-billion-dollar industry that is there to make sure it continues to grow. Now, the sad data is that almost every IED, almost every rifle, every bullet that hits one of our service members, almost every injury that occurs in Afghanistan is funded by Afghani heroin right now. So narco-terrorism is a significant problem that we have to deal with. Now, this is fatal poisonings in France, and this is interesting data. In 1995, buprenorphine becomes available. This curve here is heroin overdose deaths. This curve here is people who are given methadone. They started using methadone too. And this curve here is people who are on buprenorphine. So you can see what happened in France is that they introduced agonist therapy. And agonist therapy is not a cure. But agonist therapy becomes a ticket into treatment. So people who are just giving out Suboxone or giving out buprenorphine like they're candy are doing a disservice. People who are attaching therapy as part of the treatment are doing a positive thing. You get what I'm saying? So the chemical itself is not a cure. The chemical is not an evil chemical. The thing that's important is that we've got to make sure that we put the programs together so treatment and agonist therapy work hand in hand. Now for the military, we have to get them off in 6 months. So I've treated several people at Bragg, several people at Lee, who've been on buprenorphine, and we get them off it because you can't deploy a person on buprenorphine. Do you understand why? It blocks the mu receptor. So if somebody takes a bullet through their thigh and the medic wants to give them morphine, morphine won't work. So they can't be on buprenorphine and get deployed. If they're on buprenorphine for more than 6 months, you know, the mission of the military is to maintain a ready force. You're not ready if you're on buprenorphine. So what happens is the goal is to get them into treatment, adhere them to treatment, get them off the Suboxone, get them back to a normal state of mind. The way I tell my patients is that every drug of abuse hijacks a normal system that you have. Marijuana attaches to the endocannabinoid system. Cocaine and all the stimulants attack the dopamine system. Alcohol attacks the NMDA and the mu receptor system. Opioids attack the mu receptor system, which, by the way, your mu receptor system is the foundation for your endorphins. So if you're taking opioids on a regular basis, even buprenorphine, it tilts the balance of your endorphin system. So your endorphins are what give you your runner's high, which makes you have a sensation of being able to control the aches and pains that we all have. We have that ability right now of turning on our endorphins and turning them off. Problem is when you take opioids, they're off. And so people who are on chronic opioid therapy get into a funk. They get into a, I just don't feel good. Now, the answer is, we got to get you off the opioids. Oh no, don't take that away from me. Can't you put me on Cymbalta or give me some Lyrica or can't you give me something else? And then pretty soon the patient's on 5, 6, 7, 8. I mean, they have to have a grocery bag to bring their meds in. Is that the right answer? I can't believe that we were made to support the pharmaceutical industries. So there's got to be something other than that. Now this is looking at this past year, new initiates to different drugs of abuse. So this is based on 2008 National Survey of Drug Use and Health, and there were 2.2 million new marijuana users in 2008. There were 2.1 million new users of pain medications. These are abusers. This is not prescribed use. This is when people are getting them from non-prescribers. In other words, they are abusing or they're developing a dependency. Or if we use the new DSM-5, they have an opioid use disorder, moderate or severe. Now, we talk about chronic non-malignant pain. There's a whole bunch of things that can cause pain. And when we look at this, back pain, arthritis, and fibromyalgia, that's 80% of all opioid prescriptions in the country. Just back pain is 70%. Now, fibromyalgia is a very difficult diagnosis because if I say that you have breast cancer, that means that we have identified it, we have biopsied it, we look at it under a microscope, you have this disease, this is what we're recommending for care. If I say you have fibromyalgia, it's very difficult because the diagnosis is fluffy. And yet if you tell a person, well, this is not really a disease, they're furious because it does hurt. It's an autoimmune inflammatory disorder that has very poor boundaries. And so people who have fibromyalgia many times have been sort of rebuffed by numerous providers, or they go to a, quote, fibromyalgia specialist, which, by the way, doesn't exist, and they get put on all kinds of medications. And pretty soon they're on Cymbalta and Lyrica and oxycodone, and they're on this package of services, and then they develop what's called a medical dependency. Now we have a diagnosis we can treat. So it's kind of a crazy situation that these are called, some of these patients who get into the system become what's called iatrogenic disorders. Iatros is doctor, genic, caused by. So that means we did it. Now the same thing happens with iatrogenic opioid dependence. So you break your ankle, your orthopod puts a few pins in your ankle, he gives you Vicodin, 7.5, and he tells you to take 1 to 2 of those tablets every 4 hours as needed. I had a patient who had, this is at Andrews, he comes in, he's got blood in his urine, he's got kidney stone. He goes to the emergency room, he gets Vicodin 10, 325, 1 to 2 every 4 hours for pain. Now, if you've had a kidney stone, you need the treatment because you got to flood you have to take a lot of water, flush it out, and it's not going to feel good pushing that rock through you because that rock, by the way, doesn't look like a nice little pebble. It looks like a sand burr, okay? So it's going through your ureter and it's tearing up everything and you're just peeing blood left and right. He goes to his primary care doctor. The doctor asks him, how's your kidney stone? It's hurting like crazy. So, okay, here's another prescription, Vicodin 10, 325. In the course of 27 days, he was prescribed 720 tablets from the same pharmacy at Andrews. Now, these are all good doctors. But what happens is, and I do it myself, you got to go fishing in that chart to find the right information as to where all the people have been getting meds, because I see the last prescription fill, but I got to dig to see the previous ones. And if I don't dig, I don't see that 4 days ago we got another 80, and 8 days ago he had another 70. And so if you go back and forth, and every time you go to the ER, do you see the same doctor? No. Is the ER busy? All the time. Did you wait a long time to get there? And is the doctor looking at his watch thinking, how many more patients are out there? And so what happens is, it's easy for that to happen. Well, then when his family doctor sat down and really looked at things, he said, you're in trouble. So he admits him to Fort Belvoir, 7th floor. I walk in, and he is literally on the toilet vomiting into a wastebasket because he got stopped on everything. And it doesn't make any difference if you're shooting up heroin or you're taking Vicodin or you're taking OxyContin. When you stop it, if you have a hole, something's coming out. So he's not feeling real good. But you can see the long list of different things we have here as a problem. Now, the other thing we have is to realize in malignant pain, we treat to goal. So if you have metastatic disease, our goal is to not only decrease your suffering, but we want to actually get you as comfortable as possible. Why is that? Because we're not going to worry about opioid dependence in someone who's only going to live for 3 more months. We're going to give them what they need so they can do the things they have to do to transition. In chronic pain, if you're going to have this for the next 15 years, I do not want to get you to the point that you're taking a gram a day of morphine. And you can get to that very easily because opioids always habituate. In other words, if 30 milligrams of OxyContin twice a day takes care of your pain today, it's going to have to be 45 twice a day a month from now. It's going to have to be 60 twice a day after that because your brain actually becomes habituated or it attenuates to that medication, so you have to have more and more. The problem is that there's a thing called a plateau or a ceiling effect, that at a certain point, no matter how much more I give you, you're not going to feel anything. And that's somewhere around 200 milligrams a day of morphine. So if we put you on Oxy 80 twice a day, we're very close to the plateau. Then you say your pain's worse, I give you Oxy 80 3 times a day, and you say you're still in pain. But now I have to deal with the withdrawal. Because if you don't get the medicine, you start getting sick too, remember? And if you have a hole. So now what happens is I'm treating the withdrawal more than I'm treating the pain. If you talk to a heroin addict that comes in and says, I want to get help, they don't tell you that they still get high every time they shoot up. They just tell you, I'm dope sick. I need my med. And my med is half a gram of heroin. And so the sad part about an addiction is first it entices you, and then pretty soon you're chasing it. And when you're chasing it, it's not going to get better. You can't stop that process just by thinking it away. So we want to improve their function. We want to identify and eliminate those pain reinforcers. And those pain reinforcers are significant. If you're having marital problems and you have chronic pain syndrome, what happens to your pain? It gets worse. If you're having job problems and you have chronic pain, what happens to your pain? It always gets worse. So now we have to look at the bigger picture. Now, doctors don't make good therapists. Now that's kind of a shock to me. So I think the group from last year remembers this. My wife continues to tell me I'm still a lousy therapist. Now, she's a psychologist for the inpatient psych unit. Our 35th anniversary is this September. So she says, "You did it again." I said, "What did I do?" She said, "You told another woman to get a lawyer and change the locks." I said, "The guy beat her up." She said, "That's not therapy." I said, "Well, it's still right." She said, "But why does the patient think you're doing therapy with them?" I said, "Well, I care about them." I said, "My advice is when your husband beats you up for the third time, it's probably time to throw the towel in." And my wife says, "Yeah, but," she said, "it'd be better if you just refer her to us and let us take it, because it takes us twice as long to get her to the right place because they think you're their therapist." So Dr. Dekker is not a good therapist. But, okay? But that means I got to have people I can refer to. And so I get to stir the pot up, get things going, then I can step out and the cooks really come in and do the right work. But the reality is you need to have doctors that are willing to refer people to you and not make the situation worse. So people should do what they do well, and they should make sure that other people can do the rest. So we want to eliminate those pain reinforcers or decrease them as much as possible. Muscles that don't move are hypersensitive to pain. The patient who says, "Oh, doc, hey, listen, I really appreciate the medicine because I'm not having pain anymore." And the wife says, "Yeah, all he does is sit on the couch." I failed. Because now if I have that same patient who has pain, and their pain is 8 out of 10, which, by the way, the number system is bogus, okay? It's bogus. There's no reproducibility in that number system. When you pick up a chart that says patient's pain level is 8, what does that mean? I told you the story last year about Jose Ramon. Jose Ramon is a medicine man we used at the Phoenix Indian Medical Center. And he's a pharmacist too, and he's really tall. He's about 6 foot. He passed away now, but he was 6'3", dark, like charcoal dark. And he was identified as a medicine, as a gift to the community in Ajo, which is about 50 miles west of Tucson, because when he was 12 years old, he was 6 feet tall. Now, Pima people are short. They're like 4.5 feet tall. They always get to play the dwarfs in the Christmas play. So what happens is that he's identified as unusual. And unusual in Indian country is there's a reason. Creators brought you to this community for so he was trained to be a medicine person from the time he was 12 years old, and now when this happened, he was in his 70s. And Jose comes in and he says, "We don't understand this 1 to 0 to 10 scale. It makes no sense to us." I said, "Well, there's a thing called the Joint Commission. They're requiring us to do this." I was a liaison to the traditional healers. And I'm talking, and it's like I'm speaking French. And I said, "Yeah, that doesn't make any difference to us. We don't care about the Joint Commission." I said, "Well, actually, we have to be Joint Commission approved, and we have to have a tool that measures pain. And we'd like to use this particular policy, and we're going to you because you are the directors of the hospital, and we have to pass it through you." And Jose says, in the Otham language, now, the people who lived just west of Tucson was called the Papago Nation. As it turns out, Papago is Spanish. And Papago means bean eaters. And the Otham people didn't like that because they said that we are called the fart people by the Spanish. And we are not the fart people. Now, Ajo, which is garlic, is the capital of the Tohono Nation. All the Indian names, all of them mean the people. The Lakota, the Nez Perce, the Dene, which are Navajo, the Hopi, it means the people. The Cheyenne mean the people. And the Tohono O'odham mean the people of the desert. The Havasupai, the people of the green water, the bottom of the Grand Canyon. So they have a word I should say, they have 22 words for sand. So, and if you think the desert is sand, it's not. If you're in Arizona, it's rocky, it's hilly, there's all kinds of Palo Verde and mesquite, and it's amazingly alive. I mean, a spiritual experience is drive out to a quiet area in the desert, turn the lights off, walk out and just listen. And you'll be amazed as to how much life is around you and the smells. But they only have one word for pain. That word is scote. And so he says, this scale from 1 to 10 makes no sense. He said, 1, 2, 3, it means that you can do everything you normally do, but you're in pain. We don't even have a word for that. If you can do everything you normally do, it's not a word. It's just being a human being, you have aches and pains. 3, 4, 5, you can't pick up 2 bales of hay and off your pickup truck and bring them into your stable for your horse to eat. 3, 4, 5, you can't pick your grandchildren up and walk up a flight of stairs. 4, 5, 6, I'm sorry, 3, 4, 5, and then 6, 7, 8, pain so bad you can't put your clothes on. Pain so bad you have to have someone take you to the bathroom and wipe you. Pain so bad that you have difficulty doing the things that you normally do, and it hurts and you have to have someone else do it, making your food, going to the bathroom, getting the water from the pump. 9 and 10, you can't even get out of bed. Now, that makes sense because it's function-based. Now, he says, we call the 3, 4, 5 scote. We call the 1, 2, 3 is nothing. 4, 5, 6 is scote. 7, 8, 9 is scote. And I said, Jose, I don't get the difference. Now, he is a big guy with a big, long, arthritic finger. And he put that big, knobby finger up, and he says, you don't listen. I said scote, and I said scote. Now, I like that because it's function-based and it's volume-based. So, ouch and ouch. Now, the thing is that 8 means nothing to me. 8 means please fill my prescription. And so we have to have a better system, but every hospital, I'm sure including this one, has 0 to 10. Okay? And it doesn't help us at all. And if there are patients that are doing illegal activities, we got to stop it. Now, illegal activities would be, hi, I'm Dr. Dekker. I'm calling it a Vicodin prescription for, my number is such. Now, we use the electronic system right now for prescriptions, so we've taken away the forging opportunities, but here's the beauty of our system. Again, these are Dr. Dekker's opinions. When our electronic system crashes, which is about once a week, we have to use hand prescriptions. Now, the hand prescriptions are interesting because it says printed, and military time is different, printed 1 January 60. So what is that date? It's January 1, 1960. So I'm using a prescription pad that is 50 years old, 53 years old. And the amazing thing to me is that's our system whenever our system crashes. And it just shows you that electronics are wonderful if we have electricity, but if systems fall apart, and how often does your EHR go belly up? If it's like everybody else's, it has glitches. And so it creates problems. So our secondary system has got to be good too. But it says down here, our goal for chronic pain is not to eradicate pain. Our goal is to improve function, and when we do that, we improve suffering. We decrease suffering. I think my battery is getting low here. So I've already talked to you about the heart sink patient. Dr. Dekker, I've been to so many other doctors. No one really knows what I'm going through. You're the first one. Now, if we're giving nonverbal communication back to the patient, Dr. Dekker, you're the best doctor in the world, and my eyes dilate, and I lean forward, and I have a smile on my face. Feed me more, feed me more. I mean, every one of us do this. I mean, we work in a business where you don't get thanked, right? You don't do it for the money. Lord knows that. You don't do it because you expect every patient to thank you. You do it because your heart's in it, because you really believe that what you're doing may help change someone. So we're a little bit vulnerable to the borderline patient who has learned to be an expert at manipulation. So you need to do a system check every once in a while. Just, okay, why am I doing this? Why am I coming in on Saturday morning for seeing this patient? Why, you got to, I heard some smiles back there. So you have to ask yourself, okay, am I actually helping this patient, or am I making their situation worse by making them more manipulative? And so the goal here is you're always doing that system check on yourself, and you should be surrounded by other people who care about your professional practice, who will say, now what in the world did you do that for? To ask you, and then you better come up with a good answer. You know what, I think I'm doing this one time and I'm backing off, or in other words, I'm trying to help this person connect with the right program, right system, right whatever, to make sure things are moving in the right direction. So there's all kinds of non-pharmacologic therapies we can do. Now that's kind of important because I see a lot of people jump right to opioids. I got terrible pain here, and it's called the X-ray pack syndrome, and now we have what's called the CD system. They'll come in with, they used to come in with this 3-inch thick pack of radiology film, which it would hurt my back to carry it. And they're coming in and they flop it, and it comes down with a thud. And then nowadays they come in and they have a CD. They say, well, here's all my MRIs for the past 6 years. And if you look at the MRI from 2009, you'll see I had a terrible rupture of my L5 S1. And I still have pain going right down here, and they pull their pants down. Right here, Dr. Dekker. And I said, okay, put your pants back on. Now, the thing that's interesting is that those patients are more likely to be manipulative. Now, they're still suffering, but they've learned after years that there's at least one doctor out there or one therapist out there that will listen and give them what they want. And if they don't get what they want, they either walk out or they try other techniques. One technique is butter you up. Another technique is turn on the tears. Another technique is to get angry with them. Another one is that I know you're licensed in the state of Kansas, and I have a friend that works in Kansas, and I'm going to tell them. And I said, well, here, you want the telephone number? Here it is. So you have to emotionally prepare yourself for appropriate interaction. But you notice we have a few things here like yoga and meditation. Now, if I would have said that 10 years ago, that yoga and meditation can take care or can at least facilitate the treatment of chronic pain, I'd be laughed out of here. But the thing is that it turns out that that has very good data that shows benefit to patients who are using a variety of relaxation and introspective techniques to start to feel better. So, medication-wise, we have acetaminophen. How many cases of liver failure occurred last year from acetaminophen? This is going to be like, guess the numbers. 10,000? 25,000? It's actually 52,000 cases of liver failure. The FDA decreased 2 years ago the recommended maximum dose from 4 grams, remember you could take 500 milligrams, 2 tablets 4 times a day, to 3 grams. Because of the number of people who had permanent liver damage from acetaminophen. Vicodin, Percocet, Norcos, they're all being considered to be taken off the market, not because of the opioid, but because of the acetaminophen. And I have patients who are taking 30 and 40 Vicodin a day. So it's not the hydrocodone that's dangerous, it's the acetaminophen that's dangerous. Non-steroidal anti-inflammatory agents, naproxen, Motrin. How many people died last year from acute gastric hemorrhage from ibuprofen? 13,000. The numbers range from 13 to 16,000 every year. Over 120,000 emergency room visits because of acute GI bleeds from ibuprofen. These are over-the-counter medications, right? These are, quote, supposed to be safe. But it turns out there's a problem. So now we have this whole group of interventional doctors. So since last year, we have these doctors that you go to and they will inject your back. They'll do a facet ablation. They will do an epidural injection. And then all of a sudden we had people having this weird fungal infection that was causing them to get meningitis and die. And it was interesting that the pain medicine people, there was 2 groups. One of them said we need to use less opioids, and so a lot of them don't even use opioids anymore. They only use steroids. And there's another group that says, you know what, these steroids are going to be a problem. Now, no one ever knew that it was contaminated steroids. No one knew that, but it turns out that hundreds of people were affected by this one lab that mixed up the medication. Now, when people are injecting things into the area that touches your spinal cord, you want to make sure that the likelihood of error is 0. But we didn't do that. And so now, and the FDA never even controlled those mixing labs. So now the FDA is getting involved in that. So we got up to this point, and so what we did was we talked about the epidemic that we have with chronic pain syndrome, the epidemic that we have in the use of opioids. And opioids are an easy thing, because when a patient comes in and they're dragging their leg behind them, if I'm willing to write Percocet 5-325, number 90, 2 tablets every 6 hours, I get that patient in and out literally in 10 minutes. If I sit down and get a history and do an examination and talk about all the techniques they have to do, the non-pharmacologic interventions, getting them involved in treatment, acupuncture, physical therapy, manipulation, now it's 45 minutes. Now, if I was in private practice, I get paid the same amount of money whether I see him for 10 minutes or 45 minutes. What's the doctor going to choose? See our problem? Plus, if the person comes in and says, my pain is a 9, and I don't treat their pain adequately, I could end up having a little card that says, go to jail, do not pass go, do not collect $200. I got to go to the Board of Medical Examiners to explain why did I not take care of this patient who has severe 9 level pain when it's a measuring stick that doesn't make sense. You see our problem? So we're going to stop here, take a few questions, take a little break, and then we're going to tie up all these things. Chronic pain syndromes, TBI, PTSD, and substance abuse. As we tie